Thank you. So I'll talk about skin delivery systems, especially focusing on microneedle and iontophoresis-based products. So in our lab, we work with all aspects of transdermal delivery, making passive patches, and not just iontophoresis and microneedles, but microdermabrasion, and we're getting into laser poration and so on. So if you look at most of the products on the market today as skin patches, they're available in the form of a passive patch. So we work with that too, even though that's not the topic today. And we work with pressure-sensitive adhesives like acrylates or silicone, and we look at drug crystallization in that adhesive and how to solve those issues. So we make the patches ourselves. We have a gardener's knife. We have techniques and instruments to characterize these transdermal patches. Just to give you an idea about what we do, but that's really not the topic today. But so all of these instruments we have for characterizing transdermal patches. If you look at all of the products on the market, like I said, they're mostly available in these type of passive patches on the market today. There are about 20 or so drugs in the US market in the form of a patch. Now, if you want to deliver a macromolecule which is hydrophilic, or even if it's not a macromolecule, any hydrophilic molecule, it's really hard to deliver that through the skin because the skin is only permeable to moderately lipophilic molecules. So what can we do for these? We can use some techniques to force these into the skin. So these are not going to go into skin by themselves, but we are going to use techniques like microneedles and so on to force these molecules into the skin. So I have published a whole book on these technologies. This was supposed to be Running Man, but what happened is my flash drive didn't work this morning. So I emailed myself a PDF copy of my slides, so I'm running from a PDF. So all the animations are gone, but still should be okay. Anyway, I wrote a whole book on these technologies that can deliver drugs that don't normally go through skin. So these techniques include skin microporation. I'll focus more on microneedles. There's a couple of companies working on this, but there are other techniques too. I'm not going to talk about electroporation. We do a little bit work with phonophoresis, which is use of ultrasound. And then there are some other products on the market using various techniques, which we will not discuss today. So in the future, if you have a couple, a husband and wife, taking several drugs as patches, once we expand the scope of transdermal delivery by these techniques, this is how they're going to look with multiple patches on the body. So if you look at various products on the market, this is a fentanyl iontophoretic patch called Ionsis that just got approved by FDA about a month ago. It was approved in Europe earlier. It has a long history if you want to talk to me during lunch break. But this is a microneedle-based flu vaccine device called Soluvia. And this needle is a little bit long, about 1500 micron. But normally when we say microneedle, we're talking about 500 micron or less. There are some patches where kind of the battery is within the patch. But a battery is nothing but a potential difference between two dissimilar metals. So this technology has now been used to make a patch of sumatriptan, which also got approved a couple of months ago and is expected to be launched in a month or two in the US market. That's an iontophoresis-based product. We have on the cosmetic side, we have the derma roller. You can just roll these microneedles on your face, and then they give you these anti-aging lotions and so on to apply to the skin. And then there are some interesting devices like BioBliss patch or Wrinkle MD, where basically you apply it on the skin. Skin is conductive, so once the current starts when you put on skin because the circuit is complete. And these deliver hyaluronic acid or some peptides like snake venom type of peptides, kind of simulating the action of Botox type of situation. In the past, we had a device called GlucoWatch, which was based on reverse iontophoresis to sample the interstitial fluid and give a readout of blood glucose level. But it had to be calibrated by a finger prick. It was expensive and had some issues, so it's not on the market anymore. So that's why I say success and failures. In our lab, we have worked with over, this slide needs to be updated, with over 50 different drug molecules over the years, either targeting the skin at the sternum corneum like the terbinafine or topical delivery into the skin using a variety of techniques. The color coding here for the drug matches with what technology was used to deliver it. Also, we have systemically delivered all of these molecules by various technologies and going all the way to macromolecules, sometimes by a combination of technologies, as you can see in the color coding, and going all the way up to even monoclonal antibodies, big proteins like interferon, and so on. So these are some, for example, some of the macromolecules, polypeptides going from 1000 all the way to 150 kilodalton delivered by different techniques. Skin microporation can be done not only by microneedles but by other techniques too, like I mentioned. I'll briefly touch upon thermal microporation, then we start looking at microneedles and iontophoresis. Thermal microporation, you heat up the skin to a very high temperature, like something like 700 degrees centigrade, in a very, very localized area, which kind of flash vaporizes the water in the skin and creates a micropore, which is about 60 to 80 micron wide and maybe about 50 to 60 micron deep. So we have used this technique in a collaboration with this company. They had basically it's a filament you put on the skin, you activate the filament. Oh, this was supposed to be an animation, sorry. You activate the filament by this device, and then the micropores get created in the skin, you fold it over, now the patch is on the area of the skin that has been microporated. And that's a thermal microporation process. For example, using this technique, insulin we deliver, and once you make the pores, the patch is there, the drug maintains a sustained level, remove the patch, it falls off. And this is what we want as opposed to the peak and valley type of blood levels you get with subcutaneous injection. This was done in the hairless rat model. Based on this data, the company got FDA approval to do some clinical studies later on. Switching to microneedles. So microneedles are very small, much smaller than a hypodermic needle. Typically, they can be somewhere in the range of 200 to 500 micron. You can deliver a microneedle into the skin and just simple, and then remove it. Then you can put the patch, and the drug goes in these micropores. Or you can have coated microneedles, for example, vaccine, where the coating dissolves, needles are out. So in this case, you can coat only very little though. So this only works for very potent molecules, for example, vaccines. Or you can have a dissolving needle made of sugar, for example, where the needle goes in and then nothing comes out because the needle has dissolved in the skin. You got your micropores now. The drug could be in the needles, for example. Or you can have hollow microneedles where you're pumping stuff from the needles. All of these are much smaller than a hypodermic needle. Again, this was supposed to be an animation, but in any case, we have used maltose microneedles which dissolve in the skin. They go in and they create these pores. You put the patch on, the drug diffuses into the skin. Maltose is a sugar, so it dissolves nicely. And we have done some histology to show these pores. We have done some staining with calcine and also some immunohistochemistry using IgG to show that the drug is diffusing through these microchannels, which are hydrophilic microchannels in the skin. So we also characterize these by scanning electron microscopy to see the radius of curvature at the tip, how sharp they are, and so on. Characterize them by a variety of methods, including confocal microscopy, and we also have an instrument to see the pore uniformity of the different micropores you create, and plots it as a histogram. Basically, it compares the delivery of calcine into each individual pore relative to other pores and creates this sort of a uniformity index. Using confocal microscopy, we found that the depth of penetration following the application of a dye or fluorescent microspheres after microporation was around 160 micron, even though the maltose microneedles we used were 500 micron in length. This is because we applied it manually with the hand. If you use an applicator, like a spring-loaded applicator, the depth will change. But this is very typical. So for a 500 micron needle, the depth of penetration or the depth of the microchannel we got was around 160 micron. Using this technique, we have delivered IgG, which is around 150 kilodalton by maltose needles, but also by the derma roller, and compared the flux. There is no passive. Passive means in the absence of enhancement. In the absence of enhancement, there is no passive flux because this is a macromolecule. It will not go in the skin. Normally, you will use this technology only to deliver hydrophilic molecules, but this is one example where we had this drug which was for psoriasis, and this has a log P of 23, which I have never heard before. Log P of 23 means extremely lipophilic. So it will go in the skin, it will go in the stratum corneum, but it won't move beyond the stratum corneum because it is too lipophilic to diffuse out into the more hydrophilic dermis. Drugs have to be moderately lipophilic for transdermal delivery, not extremely lipophilic. So in this case, what we did is we made a oil in water nanoemulsion where the drug is in the oil phase, and then we do microneedles. And because of that, now this becomes kind of a hydrophilic vehicle. And because of this, we were able to get the drug into the dermis as opposed to just the stratum corneum. You have to be careful about the design of the needles too. Sometimes we get these microneedles from a chemical engineering collaborator and they look beautiful, but they don't puncture the skin at all because the spacing between those needles has to be just right for them to work. For example, this is my son lying down on a bed of nails. Now, if he was to lie down on one nail, the nail will penetrate his body. But on a bed of nails, it's not a problem because the weight of the body gets distributed over all the nails. So similarly, if the needles are very close in the microneedle array, they will cause like a deflection of the skin, but they will not penetrate. So that design is very important. So some of the needles we get from collaborators look beautiful, but they don't work. We have looked at what happens to skin barrier after microporation. And even though the pores don't close quickly, the barrier starts to recover very quickly within 4 hours by using this instrument we have for transepidermal water loss measurements. We see the recovery starts within 4 hours, but the pores actually don't close for about 15 hours. However, if you occlude the pores, that means you put a patch on the pores, for example, or anything on the pores, then the pore closure is delayed, which is good because that means you create the pores, you put your drug patch on it, the pores stay open longer. Once you remove the patch, they start to close quickly. So if you under occluded conditions, it delays the pore closure to somewhere between 72 to 120 hours. We have delivered a monoclonal antibody from the Pfizer pipeline, CMAT, and then have some data like that. Switching tracks a little bit to another technology called iontophoresis, where basically the drug is charged, you put it under the electrode of the same polarity and it pushes the drug into the skin. It's not new. It's been used in physical therapy clinics for a long time in TMJ disorders or hyperhidrosis and other things, using these type of devices in the past, and now they have more better integrated devices. But what is new is the technology has kind of evolved. An analogy would be going from the telephone to the iPhone, and now we have these kind of integrated devices. For example, this is the credit card sized device to deliver fentanyl, and this is the iontophoretic patch for delivering sumatriptan, both of which got approved within the last couple of months. The principle is the drug is charged. So for example, if the drug is positive, you put under the positive electrode or anode, which pushes the drug into the body, and then the drug is very, very effective. This works beautifully. These are, again, you saw some of this earlier. These are some of the systems based on the iontophoretic delivery, some of the products based on iontophoretic technology that I mentioned earlier. This is another example. I showed this earlier too, but a little bit more details on this one. IonSys. So this is made by this company. It was originally made by Elzal, has a long history of development. But in any case, this is approved now for management of acute post-operative pain for adult patients in hospital. So unlike Duragesic patch, which the drug goes slowly, it takes 3 days for the blood levels to come up and all. This is for instant delivery for like almost an alternative to patient-controlled anesthesia. And right now this is only for hospital use because, as you know, fentanyl is a very deadly drug and there can be a lot of abuse and accidents and overdose situations. So it has to be used carefully. But basically the patient presses this button twice and then the drug starts to come. Within the next 10 minutes, they cannot press the button again. They cannot overdose themselves to death or something like that. And then I think within 24 hours, there's a limit on how many doses can be delivered. All that is programmed into this device. So basically, we work with all of these technologies. So with iontophoresis, kind of takes a short pathway through transappendageal route, as opposed to, for example, passive patches. They just diffuse into the lipids of the skin. So depending on technology, microneedles create their own pathways. So the pathways change depending on what technique you're using. Compared to passive delivery, for example, for a beta blocker, iontophoretic delivery was much, much higher, much above the therapeutic levels. You stop the current, levels fall off. You can also use iontophoresis to modulate or control delivery by changing the current profiles. This is another example with calcitonin, where we delivered calcitonin and compared the iontophoretic delivery to subcutaneous and intravenous injection, and we found that it has a similar pharmacodynamic profile by looking at the drop in blood calcium levels. This is my student doing iontophoresis on human epidermis using the French diffusion cell with all these wires and all. When the product comes to market, it is not that clumsy, of course. It's a neat integrated patch. In the past, I was working with this company which had this device to deliver acyclovir for cold sores into the lips. So you hold the device to the lips when you get that tingling sensation, and within 10 minutes it loads up the skin with acyclovir, and then we looked at how long the drug stays in the skin. Compared to passive, iontophoretic delivery gave a lot more drug into the skin, and it stayed in the skin somewhere between 48 to 72 hours, it was gone. Sometimes what happens, let's say with this particular polypeptide, we did iontophoresis, but we don't see anything in the blood. It is going in, but the thing is there's a lot of volume of distribution in the blood, and sometimes the assay sensitivity is not there. So we can also do microdialysis, where we put a probe inside the skin, and even though we don't pick anything plasma, we can see in the probe that the drug is coming through the skin. So this is the blood level, and then this is the microdialysis, by microdialysis, the subdermal levels. So we have all those instruments for microdialysis, fraction collectors and pumps and the probes and so on. And we also have a dermascan instrument which sends an ultrasound signal into the skin and looks for the echo bag to find the depth of the probe. But this is all it does for, I think as a dermatologist, you guys can use this for many things, but this is all I used it for. For $50,000, it's not a good investment just to find where the probe is. And the depth is pretty much same once you've done it once. So I'm trying to find more uses for this instrument. Anyway, in vivo microdialysis data, again, iontophoresis is much, much more than passive. We can even put probes under the skin, in the skin, so we can get levels of drug in the intracutaneous, subcutaneous, and serum simultaneously. We also use combination approaches. For example, in this case, this is the micropore, and if you deliver just the drug by microneedles, that's fine, it is going in. The red is the AFBSA, bovine serum albumin, labeled with Alexa fluorescent tag. Green is microspheres, and when they are together, it's yellow. So this is yellow, so this is the micropore. But when you combine iontophoresis and microneedles, a lot more drug goes in, and it is diffused. You see the red? It is diffusing out from the pore, so a lot of BSA is being delivered. Again, combination with calcitonin, combination of iontophoresis and microneedles had the highest delivery. Again, leuprolide, again combination had good delivery. And we also worked with ultrasound. I didn't present too much data today. But what happens with iontophoresis, there's a size limit on how much you can deliver. It's around 13 kilodalton. So beyond 13 kilodalton, iontophoresis doesn't work. However, microneedles, there's no size limit because those pores are like 60 micron wide. Even the largest, biggest proteins, their hydrodynamic radius is still in nanometer. So there is no size limit for any dissolved molecule with microneedles. Similarly, ultrasound also we found can deliver large molecules, but iontophoresis only delivers up to around 13 kilodalton, at least in significant amounts. Larger molecules, it may deliver very, very little, but not a lot. Similarly with, this was with IgG, similarly with human growth hormone, a similar observation, the delivery achieved by because this is around 22 kilodalton, delivery achieved by sonophoresis, which is ultrasound, and microneedles, but not by passive diffusion, obviously, but also not by iontophoresis, because this is a little bit too big for iontophoresis. As I mentioned earlier, we can also modulate delivery. So for calcine, for example, this is microneedle delivery, but if we apply the current at 2nd hour and 6th hour, we can modulate delivery. For example, if you want to tailor a dose to an individual patient or something like that. And a similar trend we found with the human growth hormone. So, of course, there will be, I didn't put a lot of these type of slides, but there are a lot of, I have similarly many slides on microneedles of what are the challenges would be, what FDA will look for, and so on. But in the case of iontophoretic devices, we need to look for these type of problems, for example, dose dumping or failure of electronics. And that iontophoresis patch was hard to develop because it was hard to keep the electronics dry in the presence of the hydrogel, and they had a lot of issues with it. But of course, now it is finally approved. And again, the cost will be high, so this may not work for every drug. But wherever there's a niche need or a clear unmet therapeutic need, then these technologies could be good. Again, some of the other issues, biocompatibility, sterilization, usability, human factors would be make sure the patient can follow the instructions. It's part of FDA's device regulations. Also, when you have a normal patch, there's a lot of the drug that's left in the patch. So let's say if you have a nicotine patch, and it's supposed to be used for 24 hours. So after 24 hours, you remove that patch, you put on the new one, but the used patch still has a lot of the drug. The excess drug was required to drive the drug into the body, right? So it works by diffusion. So it's not okay to peel the patch and apply it to your dog or something because there's still a lot of the drug there. So don't do that. So we are actually working on another project where we try to minimize or deactivate residual drug, not only in a patch, but also unused prescription medications. That's a hazard to the environment, a lot of abuse potential, and drug-induced deaths have been rising over the years, now second only to motor vehicle accidents. So this project is designed to deactivate these drugs. For example, in the case of a patch, we have activated carbon-based fabric, and you basically, when you remove the patch from the body, you put it on this carbon. In the back, we have these holes. You hold that under tap water that hydrates the activated carbon and holds on to the drug, deactivates the drug, and doesn't let it go. And we are generating a lot of data for that in collaboration with this company, Verde Environmental. We have, through them, we have a SBIR, Small Business Innovation Research Phase 2 award from NIDA, National Institute of Drug Abuse, to bring a product to the market. And right now we're working with 20 psychoactive agents to develop this technology. So I think with that, these are my current students and my previous students working mostly in pharma companies in the skin delivery area. And these are some of the companies that have funded our research. Any questions?
Thank you.
Okay. Thank you.
We just will reserve. You want to say a question? Yes, please.
My name is Harry from University of Manitoba. So I have actually a couple of questions. One of them is that most of the drug delivery that instrument you have, basically very localized one, is very narrow or very small, basically area. So what happens if someone wants to deliver a bigger area, like have a chocolate square bear patient, for example, or another thing, all the things that you show actually the presence of drug in the area by different techniques. Did you look at the biological activity, for example, to see whether electroporation may change the morphology, may change the functionality of drug?
I can only remember one question at a time, but let me try. So the area question, yes. For example, we have this androgel, testosterone gel in the market that is applied on the shoulders and all. So any topical product, the area you can define by apply the gel in in more surface area. If you have a patch, you can't have a very big patch. I think the lidocaine patch in the market is the biggest patch in the market, but typically a transdermal patch is not more than around 30 square centimeter. So when we do these studies, we generally plot our data is how much drug is there per centimeter square of the skin. And from that, we can project to a reasonable patch size, which will be, let's say, 20, or maximum pushing the limits will be 30. And then we calculate that can we get a therapeutic dose. And then I think you wanted to ask about the drug in the skin.
How about the microneedles?
Microneedles also, I would say, not more than 20 centimeter square patch. Also because you want a flat area of the skin. Like for example, in a normal passive patch, it has good adhesion, it will stick all around the skin, even if the skin is bending and all that. In microneedle patch, you want to make sure the skin is flat. because if the skin starts to curve, then some of the microneedles may not enter the skin at the point of the skin inflection. So microneedle patch, I would say, certainly should not be more than 20 centimeter square patch, even though a passive patch can go all the way up to even 35 or maximum would be 40, with the exception of lidocaine. But lidocaine is different because you can cut it and all that. And then I think you were asking about finding the drug in the skin.
Any change in the molecule?
Oh, biological activity, sorry. So one of the examples I showed was delivery of calcitonin. So in that case, we measured the drop in blood calcium levels. So that's a pharmacodynamic response. We generally don't do efficacy studies, but it's mostly drug delivery studies, and these are products which are already on the market. So once we get the flux across I have worked with human cadaver skin or human surgical skin. Once we show that those type of drug levels are being delivered, we can project the flux to what the plasma level would be, or we can do in vivo studies in the hairless rat model and show the plasma levels. And these drugs are already on the market, so we know at that once you deliver that blood level, it should be efficacious. But once in a while, if it's an easy efficacy test, like in the case of calcitonin, it was the blood calcium levels or insulin in the long time ago, you can make diabetic rats by using streptozotocin or something like that. But generally, I don't do efficacy studies, and generally they're not needed. I'm mostly funded by industry, pharma industry. I've never had anybody ask me to prove efficacy. They just want to know how much drug is being delivered, and then they take it from there for their clinical studies and so on.
We'll reserve more questions as we need to go on. Thank you, Dr. Banga, for a wonderful use of electronics engineering into our medical field. Thank you. This is a small certificate of recognition.
Oh, okay. Thank you.
Thank you again.